Welcome back to the SEEDS activities, the School of SEEDS. And this time we have two different requests. Yes, the topic today is about the post-operative management, which is, we all know that now we have been through all the technology of the operation surgery, but what is equally important is about to taking good care of the patient, pre, intra, and post-operative. So the first topic will be given by one of the most famous Asian thoracic surgeons, Dr. Sihoe. He used to work for the university, but he is now moving to run his own business, right? And he is going to give a talk about the ERAS, the enhanced recovery, which is one of the most interesting topics in the thoracic surgery right now. Please, Dr. Alan, give us the, yes, thank you.
Okay, well, good evening, everybody, all across Asia, around the world, and it's so good of you to join us. I'll just share my screen with everybody. Okay, and I'd like to thank SEEDS for giving us this opportunity really to share with you this really important topic. Now, enhanced recovery after surgery, ERAS, everybody has heard about it by now, and I think I was given this title, Establishing an Enhanced Recovery Program. It's really quite a big topic, so I think in the space we have available for tonight, I think what I'll really want to be going through is what are what's the idea of ERAS? What are the key ingredients or components of ERAS? And if you're really starting an ERAS program in your own hospital, here I'll just share a few tips and tricks I think we've learned along the way. And again, it's a really compressed time frame. So if I miss any points or if there's anything you guys missed, do ask some questions at the end of this session, and I'd be really happy to share everything with you. So as I said, we're going to be talking about an enhanced recovery program. Now, this is, I think, one of the most important and yet also one of the most neglected parts of thoracic surgery education nowadays, because everybody knows about this flow chart. Everybody knows about minimally invasive surgery, how we're making great strides in techniques. So I'm just showing you some of the techniques that are being done nowadays. There's so many other things out there available. There's subxiphoid surgery, there's robotic surgery, all this other kind of stuff. And this is great. And I think a lot of our younger surgeons out there are really focused on the surgical or operative technique. And they're thinking that this is probably the key to maximizing benefit for the patients. And they think if I do great uniportal surgery, that's it. That's all the patient ever needs. Now that would be absolutely wrong. If you don't actually take an overall perioperative care of your patient, this kind of surgery is not going to do you full maximum benefit. And just to illustrate this point, I'm just going to share with you a paper that I think a lot of my close friends know. I love this paper from my good friend, John Carlos das Neves Pereira. He's a Brazilian thoracic surgeon working in Paris. And when I first met him, it was some 10 years ago, he presented his experience with this extreme fast track recovery for lung cancer lobectomy. And I was really impressed. And if you just look at this line here, these are the patients he's got eating and feeding within 1 hour of surgery, almost immediately in the operating room. And you see he's achieving that in some 99% of his patients. And you think, wow, that can't be right. You know, wow, that's pretty fast. Until you actually see the video of his patients. So here he is walking with his patient. And this is in the recovery room outside his theater. This is him immediately after surgery. Patient, he's running him up and down the corridor. He's making him do exercise immediately after surgery. And if you pay attention to that little box on the right, this is after he did lobectomies through an open incision. Here's an old guy doing squats immediately after surgery. Now he's achieving that not because he's doing great minimally invasive surgery. Back then when he first did this study, this is still thoracotomy. And he's achieving this incredible fast track rehabilitation. He's getting his patients home in 48 hours after surgery, after thoracotomy. Now, what does this tell you? It tells me two things. One is that minimally invasive surgery is not the only way to make patients recover faster. And two, it tells you you probably don't want surgery in France because that's what the surgeon is going to do to you. But anyway, this fast track rehabilitation means all this guy's doing, John Carlos is doing, he's doing a lot of perioperative management. He's here, massage, exercise, good diet, and he's achieving these great results that many VAT surgeons around the world can't do, no matter how small their wounds are. And this just rams home the message that if you want your patient to have a good result after surgery, great operations by themselves, they're important, but they're not enough. What you need to do is you need to complement your surgery with good perioperative management, and that includes anesthesia, analgesia, mobilization, chest strain management, everything. You have to put it together in order to realize the full benefit of your good surgery. There's a saying, you know, power is nothing without control. So power of operation is not enough if you can't control the patient's recovering environment. Now, we realized very early on in the early days of VATS back in the 1990s that if you do minimally invasive surgery, yeah, you can fast track your patient, get them home pretty quickly. So for many years, we used to use the term fast tracking, but today we don't use that term anymore. And because we realize that just reducing length of stay, just getting the patient out of there as quick as possible is not the ultimate goal. Today, instead of fast tracking, we're using a different term, and we're calling it ERAS, Enhanced Recovery After Surgery. Now, just to illustrate exactly what this means, I'm using this little graph. I love this graph done by two Indian surgeons in gastroenterology. So here on the left, you're seeing on the y-axis is the functional status of the patient, and that dotted line here is where the patient should be, a normal person should be at the optimum level. So if he's coming in for thoracic surgery, let's say for lung cancer, you're expecting his pre-existing state at the time of going into surgery probably is going to be suboptimal anyway. The poor patient has cancer. He's probably already had neoadjuvant therapy. So he's got suboptimal functional status. And then you do major thoracic surgery, and that's a big hit during the operation on his functional status. You're destroying, you're harming him physiologically. So it takes a big dip. And then after surgery, in the post-operative phase, you're gradually trying to build up the functional status back to as high as it can go, but it's always going to be suboptimal. Now, what you're trying to do with ERAS is here on the right. And this, I think, is very important because what you're doing starts even before surgery. Preoperatively, you're trying to build the patient back up towards the optimal level, even before you bring him into surgery. And that's quite critical. Then when you do your operation, you do have a hit, that's unavoidable, but you're trying to minimize the hit, minimally invasive surgery, et cetera, so that dip isn't as big. And then post-operatively, you do whatever you need to do to try and make his recovery better, not only a shorter time, but towards a closer to optimal level. So what you're doing here is not just reducing the x-axis, you're not just fast tracking him to make this x-axis duration shorter, you're also working on the y-axis to keep the overall functional status of the patient throughout the operative experience as close to optimum as possible. And that's the key to ERAS, and that's why we don't just talk about fast tracking anymore. You need to work on the y-axis itself. And if you really get down to it, I think just to simplify things, ERAS you can think of in 3 phases. Quite neatly, there's preoperative, intraoperative, and postoperative phases. So again, I don't have time to go into all of these in detail. So we'll just pick a few key points, I think, in each of these segments. So let's start with preoperative. I think in this day and age, I think preoperative ERAS, there's for most lung cancer surgeons, there's not a lot that can be done because unlike many other elective surgeries, our surgery is pretty time dependent. We need to get our patient from diagnosis to treatment in as short as time as possible. But remember, a lot of our patients probably come to surgery with a diminished functional status. And that's often due to cachexia, cancer, or the neoadjuvant treatment they've been given. So one of the most effective ways of trying to get the patient back to optimal status is nutrition. In particular, there's nowadays a concept known as immunonutrition. And it's known that, especially if you've been given induction chemoradiotherapy, your innate immune system is going to take a hit, and you're going to enter surgery with a slightly compromised system. So if you can actually tailor nutrition for patients before surgery, you can potentially reduce complications after surgery. So this neat little study, which was actually published in the Annals several years ago, it's not a huge study, but it showed that these patients, after 8 weeks of induction chemoradiotherapy, they're ready for surgery, and all they were given was immunonutrition for 5 days before surgery. So the difference, whether or not you give the immunonutrition, actually is significant in terms of transferrin levels and lymphocyte counts after surgery. Now, this is quite a small study, but there are other similar small studies, and I think accumulated, it does tend to indicate that even if it's only for a few days, if you actually optimize nutrition before patients before thoracic surgery, you can potentially reduce complications post-operatively. So to cut a long story short, the ERAS Society, mainly a bunch of our European friends, have already put this concept into ERAS guidelines. It's relatively weak evidence, but what they're saying is in the recent studies, malnutrition and weight loss were important risk factors. And therefore, the current general recommendation suggests that if you give 5 to 7 days of oral supplements before surgery who are potentially at risk of malnutrition, i.e. those who are maybe losing weight or have had induction therapy, you don't need a very long period of nutrition, just 5-7 days, and potentially you might be reducing complications. So that's something nice and easy to do. So that's the preoperative part. We won't focus too much on that. Intraoperative, I think, is the part where most of you in the audience will be most familiar. And this is what we're doing in surgery. And inevitably, an integral part of modern ERAS in thoracic surgery is minimally invasive. So you can pick your own medicine, whichever kind of minimally invasive approach you want. It doesn't matter. You can do uniportal, you can do robotic. It doesn't matter. There's good enough evidence today that shows that if you have a skilled, minimally invasive access for your surgery, the hit of the surgery we're talking about earlier, that kind of diminishing of your physiological status during the operation itself can be reduced. Certainly back in the 1990s and the early 2000s, a number of studies have done, both by my mentor, Professor Anthony Yim, and Bill Walker in Edinburgh, has shown that actually if you do minimally invasive surgery, the immune compromise that you're causing by doing the surgery is greatly reduced, and that will only benefit the patient in the long run. So certainly surgery, how you do the surgery, is essential. It's very important to do this, but that intraoperative component of ERAS is not just the surgeon's game. It's actually a two-step tango. The surgeon needs to work with the anesthetist. Doing the surgery by yourself without good anesthesia is not going to work. So what do I mean by that? Well, one recent example a lot of people talk about is this kind of thing: non-intubated general anesthesia. So this little video is one of my own videos. You can see even if the patient's spontaneously breathing, you can actually get excellent visualization, minimal movement inside the chest, which will allow you to do any kind of surgery you want inside the chest. And the idea of doing this non-intubated general anesthesia is you get faster recovery, less minor complications, et cetera, et cetera. So yeah, maybe there is some benefit to that. You can optimize the ERAS package by reducing the trauma of the anesthesia itself. But I understand that most of you out there won't be so familiar with non-intubated. And even myself, I don't think this is a miracle cure-all. Instead, I think there's another part of anesthesia that often gets neglected, which is even more important. And it's this part. It's the nerve blockade. It's good anesthetic blocks. And do not underestimate this. Now, I'm sure a lot of you out there are already familiar with intercostal blockade. So after VATS operation, I'm sure a lot of you are already giving your patients an intercostal block before you finish up the operation. But here's one thing that I particularly am a big fan of. We did a study for this many years ago, and it's actually preemptive paravertebral blockade. Now, there's good enough evidence, I think, that paravertebral blockade, it gives very good pain relief with actually very minimal side effects compared to things like even epidural. I think it's a fantastic block. But it's not just where you give the block, it's when you give the block. And my own advice to you is to give it preemptively before you make the incision. Now, the idea of this is that even when the patient is fully asleep, the intercostal nerves, while the patient is asleep, is still active. If you're doing your surgery and you trigger off these intercostal nerves, the pain fibers in them, the nerves get pre-sensitized. And the theory goes that post-operatively, any continuing noxious stimulation will continue to be amplified by these pre-sensitized nerves, and that will amplify the pain. So if you actually give your paravertebral preemptively, so that during the surgery, that nerve isn't triggered by the surgical trauma, post-operatively, your pain signals are not amplified. And I think we've demonstrated in a relatively simple surgery like this, needlescopic surgery, that this benefit is not only immediately seen, but it can last for up to 7 days. And so now routinely we use this, and when you couple good anesthesia with good surgery, you really do achieve pain-free lung cancer surgery. We all talk about pain-free lung cancer surgery, but I'm telling you, this is really pain-free. So this is something that I think all of us, we need to work with our anesthetists to optimize intraoperative ERAS. So that's just my little thought on that. Now, again, just skipping forwards a bit, we go on to the post-operative phase. Now, post-operative part of ERAS, I think, again, most of you know this very, very well. Getting patients eating and drinking quickly, trying to get them off all sorts of tubes and connections, get them mobilized quickly, doing breathing exercises, get them out of bed as soon as you can, and optimize that post-operative pain control. But there are so many components to this post-operative care. And I just want to highlight that every single one of these components is very important in themselves. And I'll just highlight one example. And that's the example I think we learned in Hong Kong. I just want to emphasize with this chart that, again, every single one of these components is absolutely essential. And I'm just going to emphasize chest drain management here. This is just one component. And again, to cut a long story short, for the past 12 years, I've been using a digital chest drain system. Conflict of interest, I am a consultant for this company. I won't mention them by name, and I'm not advertising them. But I'm just using this as an example. If you use a digital chest drain system, I think what we found is that the objectivity in the air leak management and the portability for the patient, they can, this patient is just day 0 after surgery, and they can already get out of bed and start walking to the toilet. These things all make a difference. How do they make a difference? Well, we evaluated new chest drain systems in a multi-center trial in China. Not surprisingly, we demonstrated again, we can reduce chest drain durations. We can talk about why later. We reduced errors occurring between nurses and doctors in reading air leaks significantly, not a big, huge amount, but significantly different. But most importantly, while the patient still had a chest drain in, we asked them 20 questions about their quality of life while they still had a chest drain after surgery. And in every single one of these 20 questions, the patients with a digital chest drain did better than the patients with a water sealed chest drain. So what does this actually show? It means that, just a very small adjustment in one of the aspects of postoperative care, in this case, chest drainage, can actually result in objective benefits in reducing chest drain durations and in quality of life and subjective benefits in terms of how the patient feels in himself after surgery. And this is just one component. This is just chest drain. And if you multiply this by all the other aspects of your postoperative care, your nutrition, your physiotherapy, your pain control, all of this adds up. And this is how you get the results that we saw, John Carlos was achieving in Paris with these very extreme fast track rehabilitation things. So you put them all together, and this is what you end up with. This is just one of the care maps that I designed. This is going back, I don't know, 12 years ago in Hong Kong. And you put them all together into a care map like this. And a good ERAS needs a clinical pathway like this. Every single day, you map out exactly what the patient is going through. At the top, you actually need to set the goals for the patient that day. This is what we're aiming to achieve. And then in every category of management, you map out exactly what you're going to do. All of this is just a summary, but every step of the way, we use evidence. We go through the literature, not just myself, the entire surgical team, the anesthetists, our pharmacists, our physios, and of course our nurses. We all get together in an MDT environment and we design this all together. And every single aspect from monitoring the patient, what investigations we order, how we're going to mobilize patients, how we treat the patient, including the chest drain management, nutrition and elimination, i.e. the bowel opening, everything, we map it out carefully so that patients achieve a good result. So you can see this is an older care map because we're discharging patients on day 4. Nowadays with uniportal surgery, at least I'm discharging my patients in less than 48 hours. But you need a good program like this. So this is the overall strategy. Day to day, this is what we were doing. This is again, a clinical pathway I designed at one of my previous hospitals. So every day, in the patient's records, we had a page for the doctor to sign off on, and there's a checklist to remind the junior doctors what management to prescribe. And this is very important. This maintains objectivity and consistency in the management. So even if I wasn't doing the ward round, even if I was traveling around the world, I know that my registrar would be following this, and he would be giving the patient exactly the same kind of management that I would give if I was there. And this ensures good quality care. On the back page is the nurse. Again, for each day of the management, the nurses have a schedule, again, a checklist to follow for the AM, PM, and night shifts so that everybody follows the same sort of thing. Now you think, wow, this seems very authoritarian and seems like a dictatorship, but there is room for variation. So at the bottom of each page, we always list variants. All patients are allowed to have variations from this clinical pathway. But if for any reason the patient cannot keep to this checklist, then it needs to be recorded exactly why they deviated. And this is important because this allows us to audit our clinical pathway, our ERAS program, see what needs to be modified, why are patients not following this step or another. And this actually allows us to further refine our program and make sure patients get the maximum benefit. So when we put this entire ERAS pathway all put together, what kind of results are we seeing? Well, if we're doing our auditing, we can actually see if patients are following the ERAS program. And what we found in Hong Kong over the years is that, male patients were not following the program as well as female patients. Patients who were smokers were following the program not as well as non-smokers. And patients who had more immediate postoperative pain on coming out of surgery, they followed the program not as well as patients who woke up feeling no pain. Now, how does this make a difference? It means that if we audit our results like this, do the variation analyses, then we can see that there are certain patient groups that are not doing so well. And we can further adjust our clinical pathway, our ERAS program, so that they get the care they need. So since doing this study, we know that, this is a male patient, he's a smoker, they probably need better reinforcement in order to comply with the clinical pathway for the best results. And we certainly know that if patients wake up with less pain, then subsequently for the rest of the hospital stay, they can adhere to the clinical pathway better. And that, again, we can bring this back to our anesthetist and say, what can we do to make sure this patient wakes up with less pain so that the rest of his postoperative stay will actually be less complicated. And when you can do all this, these are results you get. You can, if the patients adhere to the clinical pathway, they have shorter chest strain durations, and they have significantly less length of stay. So keeping to a good ERAS program, and if you can maintain it well and you tailor your program so that patients can follow well, you do get measurable benefits. And it's not just in fast-tracking patients, as I say, we're even doing things like reducing complications. So we're mentioning smokers as a high-risk group, but we found that if we got our patients to actually comply with our clinical pathway, then you can see here, the rate of complications can be very significantly reduced because patients can follow the program, they actually have a better recovery. So that's the power of a clinical pathway, and I think that's why we need to work on this. So I'm just going to finish off by giving you a few tips and tricks for you if you want to establish an ERAS program like this. So I've got quite a lot of experience of this because I've worked in various hospitals. This is Hong Kong, by the way. I used to work at this hospital. My boss actually entrusted me with drafting our clinical pathway, our ERAS program. It wasn't called ERAS back then. I drafted it in this hospital. I drafted it when I went to a different hospital, gave the first clinical pathway for this hospital. And then when we moved to the university hospital, I drafted our ERAS program there. And then when I also had to work in China as well, in Shenzhen. I brought my entire ERAS program up there, start from scratch in a different part of China. And today I'm working in a private hospital. And again, I imported and modified our ERAS program here. So in all these different hospitals, I've had to start basically from scratch in a hospital where they didn't have a thoracic surgery ERAS program. And I worked with them and I designed and modified the ERAS program until we actually had something that works. And I can tell you this, they're all working fine now, and they're still using the ERAS programs that I designed back then and modified in various ways. But in every single one of these hospitals, when you begin, there are always problems and there's always resistance from the clinical team. And we had a lot of failures and a lot of excuses for why the ERAS wasn't working. A lot of patients, they couldn't adhere to the program. And these are just some of the common excuses that I heard over and over again. Some of the staff, junior doctors and nurses said, "Oh, I didn't realize it was my responsibility to look after ERAS. Dr. Sihoe, I thought it was just you." So they don't take on any responsibility. Another one was, "Oh, I didn't realize this patient needed to be put on ERAS. I thought only if you ordered it, a patient needed to be put on ERAS." So they just looked the other way. Or, "I didn't see any ERAS instructions in the clinical notes. I didn't know that you wanted me to put this patient on an ERAS program." Or even worse, some people are saying, "Well, I don't know. I think this ERAS isn't working and therefore I'm just ignoring it." And that's terrible. So these are kind of resistance issues that you encounter every time you start an ERAS program. And then I think a lot of you out there who have already started doing ERAS, you've probably heard exactly the same excuses. So any tips and tricks on how to overcome these? Well, I've narrowed it down to 3 things I think are fairly important. I think the first thing, key to success, is involve everyone. The reason you have failures and excuses is if the entire clinical team thinks this is just the surgeon trying to be a bully and trying to do something. No, it isn't. We're all centered around the patient. So we're talking about the anesthetists, we're talking about the physios, the radiologists, the nurses, especially ICU if you use ICU, and the pulmonologists if they're involved in postoperative care also. You need to get everybody in the team involved. And this is a key word. They have to be stakeholders. If they think they're not involved, if they think this is a surgeon-led issue, they're not going to be interested. They're not going to give you their cooperation. So what we've learned is that from day one, even when you design your ERAS protocol, bring everybody on board. You can probably chair the session, but they need to be there helping you design the program, telling you, giving you feedback about what might work, what might not. You have to listen to their voices. And if they feel that they've been involved in designing the ERAS program from day one, then they will give you more attention and more contribution to the patient's success. The second key issue, oh yeah, I was just saying surgeons can be the champions of this program. The second key issue is when you do design your ERAS program, it needs to be balanced. Now, I showed you my care map and the daily checklist that I've been using. And some of you might say, gosh, that's quite a long checklist. There's so many items. So you need to be balanced. If you do an ERAS program that is too simple, it's too vague, not many checklist points, that's fine for the staff. They find it easy to follow, but you're not going to achieve anything. If you don't have any action points, any issues that need to be addressed daily, you're not going to achieve your ERAS goals. You need to be quite detailed. You need to be objective. You need to be consistent in your approach in order to make the ERAS work. So something very simple or very vague, let's get the patient out of bed. That's a bit too vague. You need to say specifically what you want to do at what kind of time and what date and how you're going to achieve it. You need to be fairly detailed. But on the other hand, if you're too detailed, so specific, then you'll find that it's impossible, not only for your nurses, but also for the patients to follow. They just can't do it. There are too many things to follow. And after a while, the whole program is not going to work. You're never going to get 100% compliance. So it's very important when you design the ERAS program to balance it between being too simple and too detailed. And again, that comes back to working with your entire team. There's no one design that will work for every single hospital. You need to work with the staff in your own hospital and find where that optimal balance is between too simple and too detailed for your staff and your team. And last but not least, and I think this is one of the most important things, is you need to audit. You need to feedback. So remember, I was saying earlier, you can allow for variations in the ERAS, but every time you do a variation, you need to record it, find out what went wrong, and then feed back to your staff. You need to have regular audit meetings, not just ad hoc audit meetings, regular. We fixed it so we had every month or every 2 months, we would have an audit meeting for our ERAS program. All the cases that have been on ERAS, we go back, did this patient comply? Why did they not comply, et cetera, et cetera. And if you feed back the results to the entire staff, all the nurses, all your surgical team, everybody, then you're actually encouraging good behavior. You can see where things work. Tell them, great job, this works, keep going. Or if you see that some people are doing things wrong, you still need to tell them. Don't blame them, don't criticize, but you do need to tell them, hey, we can be doing better in this regard. Or why didn't you comply? Is there something we can change to the program so that you can comply better? And if you have this feedback loop, keep feeding back your successes and failures, that's how you get the whole team better involved and get their contributions to making things better for patients. So that brings me to the conclusion. So this is all I want to share. I think good surgical care nowadays is not just an operation. You need to do the pre-op and the post-op together. And all together, that is ERAS. That's the only way you can deliver the best possible care for your patients. In terms of pre-op, there are many aspects, but I think in our practice in thoracic surgery, I think malnutrition and optimizing preoperative nutrition is probably the easiest goal and the most relevant goal for most of us. Intraoperatively, it's not just surgery. It's a surgeon and anesthetist partnership. You need to bring your anesthetist friend along on this ride. They are going to help you. Doing small wound surgery, reduced wound surgery alone is not going to give you pain-free surgery, but your anesthetist working with you can do that. Post-operatively, too many details to mention, but what you do need is a comprehensive care map. Every single detail, every single facet, like with that chest strain, is going to make a difference. And it's up to you to work with your team to bring it all together into a comprehensive care map. And the key to success, involve everybody, balance the design, and make sure you audit. And that's all I have to share with you today. Thank you very, very much.
Thank you very much, Alan, for your
Thank you.
excellent talk as usual.
Thank you.
Yes, and I think we would ask Harish to give a talk, and then we come back to the Q&A session at the end. Will you still here?
Yeah,
Alan?
I'll be here. I'm looking forward to this talk very much.
Okay, and then we move to the next talk by Dr. Harish Mithiran. We all know him very well. He worked for the National University of Singapore. And today he will give a talk on the management of the post-operative complications. Hi, Harish, you ready?
Let me just check my volume.
Yeah, we can hear you well.
Okay, wonderful. Look, it's a bit dark on my side. I'm just going to stop my video and I'm going to put you guys to the presentation straight. Okay.
Yeah.
Okay, great. Thank you everybody for coming to our seats talk today. And so I was given a very large topic by Dr. Sun, and we're going to talk about management of post-operative complications in thoracic surgery. Now, this topic is so huge that the last time I gave this talk, it was an hour and a half long. But Dr. Sun said, look, you got 30 minutes, so I'm going to put my timer on, and I'm going to try to focus on the complications I've dealt with, and a few of the cases are here on my presentation and my cases with complications. So I think the first thing I want to give this quote: the optimal strategy of reducing the impact of any complication is basically preventing its occurrence. So what's important when we deal with any patient, just like Dr. Allen said earlier, you have to do an ERAS, so do a meticulous pre-op evaluation and do a good patient selection. So in my practice, all these patients go through kind of a review. You make sure you get a good lung function test. We get exercise testing if they got a poor lung function test. We ensure they have aggressive preoperative pulmonary rehabilitation. We get them to stop smoking. We manage their chronic diseases pretty well. We improve their nutritional status. And of course, we need to evaluate most of their cardiac status, because most of them that come to us basically are generally chronic smokers, and they have concomitant heart disease at the same time. And so you must make sure when you're doing the surgery at the time, you actually take appropriate operative care. So it's important that a lot of the young surgeons today, or even myself included, we all want to do VATS, but it's important that if it becomes too difficult, whether it's uniportal, you can always put another port in. You can do 3-port, 4-port, even 5-port VATS. So you can even do a lateral thoracotomy, but make sure you do the surgery pretty well. The size of the cut is not important, but the most important thing is to get the pathology out. The second thing we, like Dr. Allen mentioned, we must have adequate pain control, and we should have strict guidelines for our routine post-operative care. So in my practice journey with patients who undergo any types of lung surgery, what we do is after the surgery is done, whether it's a lobectomy, we put the chest drains on passive or gravity mode. If it's a bleeding patient or a patient who had decortication, then I'll put on some suction first on day 1 and then put it down to no suction on day 2. I get a chest x-ray in the recovery bay, and the next morning they have a soft diet, sit out of bed, they ambulate, and they get chest physiotherapy. We also get a routine blood test for them and chest x-ray in the morning, and we have a certain criteria that if there's no air leak and there's a light, the drainage is minimal or under 300 mils, and if the morning x-ray looks okay, we take out the drain and we repeat an x-ray. For lobectomies, I'm a little bit more concerned, so even if we take out the drain, we keep them for 1 more day, we do a repeat chest x-ray the next morning. So if they're well, then we discharge them. So most of the main complications we actually feel in thoracic surgery, but what we have is actually mainly either technical, pulmonary nature, that means they get a pneumonia, an infection of the lung, or it can be cardiovascular in nature. So there's a whole list if we were to go through it, and I'm actually not going to go through all these major complications, but mainly I'm going to focus on the 4 main areas, which is bleeding, air leaks, persistent pleural space, and empyema, which is the majority of the complications we generally deal with. So post-op bleeding actually is kind of becoming more and more uncommon in thoracic surgery. And the data today shows that the approximate risk of actually post-op bleeding is almost up to 3% only in thoracotomies and under 2% in VATS. And really on top of that, we only re-explore maybe under 2% of those for open and under 1% of those for VATS pulmonary sections. And so it's important that we actually do a pre-op risk assessment for bleeding. So a lot of our patients actually are prescribed some sort of anticoagulation before they undergo surgery. So we must assess for that. But what's more important is that a lot of people today are taking herbal medicine. And then I got this data and it said that almost 40% of Americans and probably more than 50% of Asian population are taking herbal medicine. And what's important, we all know this extra strength ginkgo. And if you look at it like ginkgo, ginseng, saw palmetto, garlic, all these actually cause some sort of platelet dysfunction in the patient. So when you're actually doing the surgery, you're always wondering why they're so oozy. And when you actually go after the surgery and you ask them, they said, oh yeah, I've been taking ginseng soup. And then you go, okay, we should stop that. So nowadays I do a thorough history and I make sure that I go through everything. I talk to them and tell them, look, you got to stop all your herbal medicines for at least 2 weeks, even if it's the vitamins you get from the herbal shops, you should stop it. If they're on warfarin, of course, it's kind of a standard aspirin. We usually stop it 7 days before, unless they have a stent inside. I'll discuss with the cardiologist if I can stop the Plavix, but I will continue with aspirin. And of course, patients who have post-op chemo or RT, they always have a higher risk of bleeding. So what happens when a patient is bleeding? What you need to take into account basically is that if the output is very high, like more than 1,000 mils in an hour, then you need to you need to take the patient back. However, if the drainage is about 200 mils per hour for the next 2 to 4 hours, you should correct the coagulopathy and check and see if you need to take the patient back. And of course, if there's sudden output of more than 400 mils, you should also be careful to take note of that. And of course, if you get a chest X-ray that looks like this, then you definitely need to take the patient in. There's no point waiting around for this kind of cases. So when you do, you have a patient that's bleeding, you make sure you take the patient in, make sure you get all the bloods required and stand by, because there's always a chance that something can go really bad and you need the bloods on standby. So historically, basically, if you have a post-op bleeding, there's always a high risk of death in these patients. And most of the time, the bleeding you can see can come from the mediastinal bronchial vessels, from intercostal vessels, we do a thoracotomy, or from pulmonary vessels, about 70%. But majority of them actually don't have any specific bleeding site. It's just generally coagulopathic. And so you need to go in there, maybe do a washout and recheck everything again. So in the operating room, you must make sure you have a systemic evaluation of all the bleeding points. And if it comes from a major vessel, like if the pulmonary artery staple line opens up, or if you tied it and you clipped it, that slipped, then really the survival from them, because they bleed out really quickly, it's very, very tough to get in time. So the survival is extremely low. But most of the time, you can see that you get oozing from the staple line. Basically, we can control this either using a Prolene stitch or even placing a clip. And if you're going to re-explore, if the bleeding is bad, the blood pressure is low, you should just do a thoracotomy straight away. But if you have time and the patient is kind of stable hemodynamically, then you can actually do it through VATS. So I don't have a post-op bleeding video, but this is an example of what happens when small pulmonary artery or the truncus branch is torn. And intraop, it looks like there's a lot of blood, but actually doing VATS, everything's magnified 2.5 times. So I'm just going to jump to it. And what we did was we placed a stapler around the bleeding vessel over here, and we clamped the stapler, and we just waited for about a few 30 seconds or so to make sure that we got the vessel thoroughly. And after we sucked everything out, we stapled it, and then there was still an ooze like this or spurter like this. So I think maybe the staple line was oozing, or maybe there's a small tear there. And this can easily be controlled. Like I mentioned, if you see this in your post-op cases and it's bleeding post-op, you can just put a clip, and that will sort out your problem. So another thing we can use is actually things like Tachoseal or hemostat agents. So again, if you dissecting very close to the vessel and you're trying to get that adventitia off, sometimes the heat from the diathermy can actually burn the vessel. And what we do is we packed it with Surgicel, and we waited for a little bit, and we try to put some patience in ourselves and just compress and put pressure and wait. But after doing that, you can see that it's still bleeding, and it's still coming out a lot. So what we can do is we can place a Tachoseal over this area. So Tachoseal is actually a good hemostat for small spurters, even in the pulmonary artery. But the problem you always find with Tachoseal is, it always is like a biscuit, it always gets crumpled up. and so you have to actually put it in carefully, especially if you're doing uniportal. You know, you have to place it in and place it in nicely over the bleeding vessel. And once you put it down, you actually just have to be patient, and this is the part where you just need to compress for about 3 to 4 minutes and just hang in there and wait. And eventually it would look something like this. So that can seal off a small bleeding vessel. And so Tachoseals are good to use if you find a small bleeding post-operatively if you come back in again. So here's a case presentation. Just some simple cases. Some have videos, some don't have videos, some have x-rays. So I'll show you guys this. So this is a 20-year-old boy who had just a spontaneous pneumothorax, his second episode. And so we went in, we did a left VATS and embolectomy and pleurectomy for him. And post-op, it was quite uneventful. Even the surgery was uneventful. But we noted that on post-op day 2, the chest stream was still very bloody, and usually you don't get this. And it was coming about 100 mils a day, but we thought, look, we'll sit on it. The lung is expanded. It will probably tamponade it well. But on post-op day 3, you can see here the haziness is increasing more and more. And we looked at the hemoglobin trend. You can see it's continuously dropping. So this is the point where you have to decide to yourself and say, look, should I continue to watch, or because the HB is continuously dropping, the output is still bloody, you should take the patient back and just take a look. And of course, when we went in there, we didn't find anything wrong. We just found we just evacuated all the hematoma, we cleaned everything up, and we just did extra hemostasis, because when we do a pleurectomy, sometimes the small capillaries can bleed and maybe tamponade and stop by itself. But I think it's important to go in and take a look, especially after day 4 when the hemoglobin continues to drop. So another case I want to show you is a case of I call this a recurrent whiteout lung, and it was a very difficult case for myself and the team. So we did a surgery, had a patient with a right upper lobe mass, and the tumor was involving the second and third rib and also the right middle lobe. We biopsied it. It was an adeno-CA. And so what we did was we went in and in intraop findings, we found the tumor to be densely adherent to the second and third rib, and it was also involving the middle lobe. So we did a right thoracotomy, we resected the second and third ribs, we did a right upper and middle lobectomy, mediastinal lymph dissection, and we reconstructed the third rib with a matrix rib. And the sixth rib is because while we were retracting, we fractured the rib. So we thought, since the set is open, we fixed the sixth rib along with it. So the post-op x-ray was this. And on post-op day 1, he was sitting out on his chair. He was having his breakfast, and he was very well. And so the ICU team sent him up to the general ward in the evening. But on post-op day 2, he was quite breathless, and he wasn't feeling right well. We did an x-ray for him. You can see that it looks like there is a collection here again, and we were very worried. But you know, looking at the HB was actually stable. So because he was more and more tachynic, we dropped him down to the ICU, and we did a CT scan for him. And what you can see here is actually not actually blood, but more of a consolidated, collapsed consolidated a lower lobe or remnant of the lower lobe. So because he's intubated, we did a bronchoscope for him, and we sucked all the mucus out, and the lung re-expanded pretty okay. So he remained in high D. He was extubated on post-op day 3. And then what happened was, after we extubated him, we had to re-intubate him on post-op day 4 because he was a bit acidotic. And then we said, okay, he got better, and then we extubated him again on post-op day 6. But on post-op day 7, this is the x-ray again. Again is a wide-out lung, but this time the HB dropped from 10 to 7. So we got another CT scan for him, and you can see a large, huge hematoma collecting over here. So we went in, we did a right thoracotomy, we evacuated all the clots, and we couldn't find anything in there. There was no obvious site of bleeding. There were some raw surfaces, and we checked the middle lobe and upper lobe stump. Everything was intact, and so we packed the raw surface with Surgicel, and we sprayed some aerosol glue with the raw surfaces. So post-op, this is how the X-ray looked like. And on day 10, from the first surgery and second day from post-op, he was getting better. He was ambulating. So we decided, okay, we'll send him up to the ward. And what happens is on post-op day 4 from the second surgery, we get this. It's another whiteout lung again. But this time, again, the HB was from 10 to 10.2. So we thought, okay, here we go, another mucus plugging. So we called the physiotherapist, and we got aggressive chest physio for him. I had to walk him around the ward and make sure he gets up and mobilized. And right after that, we repeated an x-ray, and the lung re-expand again. and then we discharge him on post-op day 14 with this X-ray. Recurrent widening of the lung can not only be because of bleeding, but it can be also because of mucus plugging. The lung completely collapses. So you have to take into account the HB and assess the patient thoroughly. So that's bleeding. Now I'll move into the second part, which is a post-lobectomy space, which we generally always deal with. And the post-lobectomy space basically is something that is so common among thoracic surgeons, and most of the time it can be a physiological airspace. It can be because of air leaks, subacute emphysema, or it could be because of a reduced lung compliance. And a lot of times we basically we do a lobectomy, there's a space, and everyone tries to worry, okay, do we increase suction, don't we increase suction? And so what's important is, I always tell my residents, is treat the patient and not the chest X-ray. So that's very, very important to assess them properly. So one of the main causes basically is the physiological residual space. So when you take out an upper lobe, what happens is that the lung cannot expand fully straight away to fill up the whole space. So with adequate lung compliance, and when you evacuate the air pocket, eventually the lung will expand and fill that space. So here's an example of an upper lobectomy that was done, and you can see there's a space over here, and we had no air leak. So we're very comfortable. We took the tube out on the next day, and when we repeat an X-ray on post-op day 2, you can see the lung actually expanded pretty well, and the patient was well. Now, what about air leaks? So when you have an air leak, most of the time, we always tend to worry. We said, okay, is this a bronchopleural fistula, or is it actually an alveoli air leak? So most of the time, these air leaks are alveoli pleural fistulas. They're not bronchopleural fistulas, so we don't have to be so concerned about it. And I'm not going to talk about the management of BPFs here. I'm just going to focus on the alveoli air leaks. So when a patient has a leak, most of the time, they have to stay in the hospital. So how do you know this is a prolonged air leak? So the STS actually defines it as lasting more than 5 days. And what's this number 5 days? How did they come out about it? It's actually basically because they exceeded the average stay of a normal lobectomy patient. And so why are we so worried about air leaks? I mean, most leaks will settle by itself anyway. And why is that so? So besides just patients staying in hospital longer, what it can be associated with is basically they can get atelectasis, they can get a pneumonia, and what's worse is we don't want them to get an empyema. All right, but please understand one thing, that most of these leaks, generally even the longest ones, will stop within 2 to 3 weeks, or at least 95% of them. So what's the risk factors of getting these post-operative air leaks? Well, COPD patients, poor FEV1, smoking history, diabetes, chronic steroids, presence of adhesions, if you do an upper lobectomy or bilobectomy, and if you basically develop a pneumothorax together with an addict, and that can actually prolong your air leak status. So there's a paper by Sunil Singhal in ATS, I think it's published in 2009, and he looked at it, and so when you see this paper, you tend to not be worried too much, because if you notice that almost about a quarter to half of your patients will have a post-op air leak on day 1, but this number will significantly come down to just about 24% on day 2, and eventually by day 4, under 10% of your patients generally won't have an air leak anymore. So if you do have an air leak and you're worried about a patient who has an air leak, what is important is that you intraoperatively, you have to plan ahead and to prevent that. So make sure you mobilize the lung fully. If there's any adhesions, take everything down. If the lung has some sort of empyema peel on it, please decorticate the lung. You can free the inferior palmar ligament. You can do a procedure called pleural tenting. You can use surgical sealants like Neovil. You can use buttress sutures, or you can use tissue transposition. And so once you do all this stuff and the patient still comes back to the ward and he still has an air leak, so what do you do? Now there's an air leak over there. Do you do suction, or do you not put in suction? So generally what suction does is it can help to improve the lung expansion. It can minimize the residual pleural space, and of course you can suck out all the blood and whatever's inside the fluids that's inside. But if you don't put on suction, and this is the theory that I abide with, is that it prevents basically increasing the airflow through the visceral pleural defects. And when that happens, the lung can actually sit on itself and seal faster if there's no suction. So traditionally, usually most of the time, we used to post-op, we used to put the patient on 20 suction and wait it out. But I think from a lot of people who did a lot of lung volume reduction, they actually started questioning the need for actually suctioning on our post lung resection patients. So what's the evidence out there? I mean, if you look at a few papers over here, this is published in thoracic clinics, and you can see here that NES is no external suction, like Robert Soffolio, Marshall. Out of these 6 papers, 1, 2, 3, 4 of them basically suggested no external suction, and 2 people said you need to put it on suction because their results were different. So what's the real evidence out there? And there was a big RCT, a meta-analysis done, and this is published in ICVTS, and they looked at over 1,600 patients. And if you see patients who were placed on suction and no suction, those who had prolonged air leak, of course, is not significant, but you can see the numbers were trending to lesser or less prolonged air leak if you don't put suction. And what about post-op pneumothorax? So this was significant, but of course, if you increase the suction, the lung will expand. And so post-op, you won't get a pneumothorax, but you still have an air leak. So when they looked at post-op pneumothorax, of course, if you put on suction, you won't get the get a pneumothorax. How about duration of chest tube? Again, both were not significant, but the numbers were trending more to no suction. So those without suction actually had a lesser duration of chest tubes and also a lesser duration of air leaks. And the last one, of course, length of hospital stay. So those without suction actually had a lesser duration of hospital stay. So the key question is, which is better? And so the findings were that suction resulted in lower occurrence of post-operative pneumothorax, however, longer chest tube duration and same length of hospital stay. So really, at the end of the day, it's up to your practice and what you feel. And so in my practice, generally, I don't apply suction in any of the patients unless they have a large or symptomatic or growing pneumothorax and there's progressive subacute emphysema, or that the patient has actually clinical deterioration. And I put them on suction if they go for decortication or have a hemothorax or have a very big bloody output. And so what happens then? So now the patients are in my ward, they have a prolonged air leak, it's more than 7 days, what do I do? So I usually use non-invasive management. I just put them on a Heimlich valve, and this is the bag we have. And that's how we put it to the patient. It's like a handbag they carry, and sometimes they can fold it and put it in their pocket, and they go home with it. And we check this component here, and I get them to cough, and you can actually see if it moves or not, and then you know if it actually has an air leak or not. So when do I place on Heimlich valves? Basically, if I feel after day 7, it's a small, stable asymptomatic pneumothorax on a water seal. If I'm not sure whether it's a true air leak or is there a residual space issue, what I do is I do provocative clamping. So what I do is I clamp the chest tube early in the morning, and I clamp it for 6 hours. I monitor its vitals, and I repeat an X-ray. So there's no increase in pneumothorax. I usually take the tube out. However, I'm really unsure, and sometimes it drops down by half a centimeter, and I'm really still not sure. I should keep the tube clamp overnight, and I repeat an X-ray the next morning. And if it's stable or not increasing, I then take the tube out. But I do this always the first thing in the morning. I think that's important, so you can actually make a decision, and the patient doesn't have to stay a long day. So when they go home with the Heimlich valve, what I see them back in the clinic in a week, and then I get them to be the first patient of the day. I get a chest X-ray, and I check the air leak by the cough test. And if there's no air leak, I'll still do a provocative clamping. I'll clamp them for 6 hours. They'll hang out in the clinic for 6 hours, and I'll repeat an X-ray. If there's no increase in pneumothorax, I'll then take the tube out, and I'll see them back in the clinic in a week's time. So if they still have persistent leak, and this is going on for more than 2 or 3 weeks, then generally, if the X-ray shows the lung is expanded well, I can do a bedside thoracoparesis for them. So there are other ways to manage these things, and endobronchial valves and surgical intervention. And so I'm going to get into a case presentation here. Do I have time? So I've got 8 more minutes, so I'll just run through this quickly. I did a uniportal VATS for a patient, wedge excision of the posterior segment lesion over here, and they came out to be an RNO-CA, so I did a completion right upper lobectomy and middle lymph node dissection. And this is the post-op X-ray. She had a small leak, it eventually resolved. On 2 weeks post-op, when she came back to the clinic, you can see here that there's actually a fairly large pneumothorax, but she was so well. And what's funny is that I didn't see any fluid. So I thought, oh, is this a bronchopleural fistula? But she had no symptoms at all whatsoever. And I asked her, look, I'm going to admit you and put in a chest drain for you. She said, nope, I feel really well. I'm going to wait it out. So she refused to come in. So we said, okay, that's great. So when we saw her back in the clinic 6 weeks later, the lung seemed to have re-expanded a little bit better. So we thought, okay, maybe it's a compliance thing. Let's sit on it. And she was so well. What's interesting was 3 months later, she came back, and you can see here's a huge pneumothorax. So immediately we thought, oh my God, she's got a bronchopleural fistula. So let's go in and let's deal with it. So I convinced her to admit her. We got a CT scan for her, and the CT scan showed the big pneumothorax, but really there was no bronchopleural fistula from the scan. And what we did, we told her, we said, you know, when we put in the chest tube, there was a lot of air leak. There was about 500 mils per minute. So we said, look, we need to take you back in, and we took her back in. We did a bronchoscope with the stump was intact. So what we did was we did a right VATS, and I'll show you the video. And probably the video is best. So I put this video together, and the initial surgery here, you can see here the lobectomy was done, but you can look at this raw surface over here, and there's a few bubbles, and you thought, okay, that should resolve, and it'll be fine. So you can see here, there we go. And there's this raw surface over here. Now, initially, I could have just put some sutures in and everything would have been well, but I don't know why I decided to do this instead. I placed surgical snow over that area. And then I sprayed lots and lots of glue over that area. And I said, okay, let's put a chest tube and she'll be fine. And she did do well post-op. And when we took her back in 3 months later, this is what we found. So you can see here, these are all the snow and the glue. The glue dissolves after 14 days, but I think the snow stays up, the Surgicel snow can stay up to about 2 to 3 months. And so you can see the surface over here has all the probably remnant snow and probably Surgicel and stuff. And we sucked that, we cleaned it all up. And then we did the air leak test, and here we go, all the bubbles are coming back out again. So this lung actually never healed, and one of the reasons I thought is because I put so much stuff over it that it actually never got to touch on any of the pleural surface or the mediastinal surface, so it never formed that adhesions and never actually healed thoroughly. So what we did was we just sutured back that area, and we put in a chest tube. We just checked it again, and that was clear. So post-op, this is an X-ray pre, this is an X-ray post, and 1 to 2 months later, she still had that residual space, but she was actually quite well. So we just sat on it again, and this is an X-ray 5 to 6 months later. We did a CT scan for her. The lung had expanded and filled the space, and eventually at 2 years, this was an X-ray. So sometimes we also get it in patients that we did a pneumothorax for. I did a pleurectomy for the patient. You can see here the pleura is stripped off, but the leak kept on being persistent. And we found that there was another bubble over there. We probably missed introp. So it's important that you don't sit on it too long, especially in primary spontaneous pneumothorax. So you go in there, and you can surprisingly no adhesions formed at all with the pleurectomy for this patient, except just at that area where that leak was there. So we went in there and we stapled off the remaining part that was leaking, and eventually we put powder inside for the patient, and that sorted the problem out for him. Poon, do I have time?
Yes, you have a few minutes.
A few minutes. Okay, so I'll just go to the last part, subacute emphysema. So this is also something we deal with all the time. And what is it? So basically, it's air traveling the subcutaneous plane, and usually air follows the path of least resistance, and it can easily dissect through the pleura that you actually cut and go into the subcutaneous fascia. And so basically, most of the time, symptomatic subacute emphysema basically is generally perceived by the patient. They're the first ones to tell you, doctor, I'm not feeling well, my chest looks like Superman, or the family member will say, look, his face is puffing up, or what's really bad if they're starting to get a change of voice or their eyes start to swell. So, why does it happen? Basically, in lung resections, when we resect the lung, the air will go through an area of least resistance. So it can happen when the chest tube is blocked, or there's a large air leak that the leak itself cannot be drained by the chest tube, okay? And sometimes what's even worse is that you get this thing called recalcitrant subcutaneous emphysema, where the area that is leaking, it sticks to the pleura and forms adhesion. So there's a direct connection with the broken pleura. And so how many chest tubes you put in, you'll never be able to solve this problem and you take the patient back to surgery. So I went and looked up, of course, subcut, if it's small like this, you can sit on it. If it's big like this, you generally tend to be very worried for the patient, and you want to take some action. So I looked up some classification. I think the only one that came up here was published in the Indian Journal, and they classified subacute emphysema according to these grades. I don't know if many people apply it, but I think it's something to look at. And what do we do once it happens? And I think there's a classical video on YouTube on subcutaneous emphysema management. I think it was in one of the hospitals in the UK, and they actually made cuts on the patient's skin, and then you can see the bubbles go through. So your treatment options, and this is the incisions they made. And you can observe the patient, which we generally don't do. We will increase the suction, or generally I will put another chest tube inside a large bore, and sometimes I get a CT scan to make sure I'm not having a loculated pneumothorax, so I'll do that. But they talked about incisions, and I completely don't agree with this, because I think it's very, very morbid for the patient. I think what's important is that we don't treat the symptom, you need to treat the problem. And the problem is actually the lung that's leaking air and going into the pleural space defect. So you need to do that. You don't make skin incisions on the patient. I completely disagree with this method of treatment. So either you put in another chest tube and you drain the air leak out, or what you can do is increase the suction, or if it really needs to be, you need to take him back and go in for surgery. So Robert Soffolio published a paper on this, on his recalcitrant subacute emphysemas, and what he did was he made a single VATS incision. This is during his robotic time. He'll just place a single incision, and he noticed that a lot of times his recalcitrant subacute emphysema is because that part of the air that's leaking is actually stuck to the pleural surface. So he just takes it down with a sucker, takes the adhesions down with a sucker, and sometimes he staples that place off, or he just takes it down. And then he basically says that now that the leak is no more in continuation with the pleurals, with the subcutaneous space, he places the chest drain, and generally most of the time his 63 out of his 64 patients, actually the subacute actually resolved in 24 hours. So it's one thing to look at, that you must always consider a reoperation if the subacute is really bad, you can't confront it with the chest tube. So in my practice, the subacute emphysema, what I do is I get a chest x-ray to see if there's a pneumothorax. If there's a pneumothorax, I'll put in make sure that I check the chest tube, make sure it's milked. And if the pneumothorax persists, I'll place another large bore chest tube and place them on suction to get the lung to expand. If there's no pneumothorax and the lung looks expanded on chest x-ray and he's still got a subacute emphysema, I will make sure to do a CT scan for his patient, because sometimes you can get loculated pneumothoraxes that you can't see on x-ray. And I'll get them to place a image-guided drain into that place and place them on suction. All right. So my last thing I'm just going to show you is a difficult complication, and I hope none of you all have this. It's a straightforward thymoma patient, non-myasthenic thymoma. And it's one of my early cases that I was doing. And you can see here, this is a large thymoma. So what we thought is, because it's such a narrow space, we'll take the thymoma out first. And we resected it. Just jump through this. Okay, so we just took the thymoma out first. And then we said, okay, we'll then do a completion thymectomy. So here am I trying to get the superior horns a bit further. I thought I'll put a clip there. And then what we did was we used the ligature, and we're dissecting it. And this happened. So lots of bleeding, and immediately we're thinking, oh, is this, without a doubt, you're trying to convince yourself it's not the innominate, but it is the innominate. So the first thing to do is always, like I said, in the 4 Ps, is to pack, put pressure, have patience, get poise, and of course start to pray. But praying is not going to help here. What you need to do is we had to open the patient up, and we had to repair the innominate vein. But what I wanted to come to is not about me repairing the innominate vein, but mainly my post-op x-ray. Can you see something over here? and that's a remnant gauze inside the patient. And so, of everything you do, I think what's important with dealing with this kind of things is that you always have communication with the family. You explain exactly what has happened. It's very important to tell them, you had an injury, you had to do a meniscectomy, there was a lot of rush and chaos a little bit in the theater, and somehow or other the gauze count was wrong, and just be truthful, be honest, and speak to the family about it. And they were very, very understanding. And so we took the patient back, and we did it through a VATS this time, and we managed to get the gauze out. This is the post-op X-ray, and surprisingly, patient was great, and she went home after a few days later. So the last point, and the last 2 minutes I'm going to go to is with all these complications, it's important that we don't point fingers as a team, but more importantly, we learn from our errors. And I want to bring this up about what the fighter pilots and airline industry does is no fault reporting error. And so a lot of times we do these operations, and while we're doing the surgery or even post-op, we develop these complications. As surgeons, we manage these complications and the patient gets better and go home. But a lot of times, many surgeons don't speak about their complications. They don't say, what happened and how they actually do it. And the many reasons for it is fear from your colleagues, fear from the hospital, fear from the patients. And so it's important that we get together and you have something called no fault reporting, because it's important that our broad goal basically is to reduce errors and how we can teach everybody else to not have the same errors that we've done. So if you do it by yourself, your colleague's going to get shot down. But if you train more and more people to do it, you can actually avoid all the missiles coming at you. And that's very, very important. So it's important to go in there. So my last slide basically is good practices and no fault reporting. Basically, we need to find the root cause of the errors, and most importantly, not establish blame or liability. We must have a good reporting system where we can give feedback and understand the results. We must use a non-punitive approach to this reporting. We must make sure that the reporting is straightforward, easily accessible to all and at every level possible, and make sure that we always keep it in electronic or hard copy, and it should be made unambiguous and easy to use. So a wise surgeon once told me, if you haven't got any complications, you haven't done enough. And what's important is that we have to always, Atuga one day says that what's important is we want perfection without practice, yet everyone is harmed if no one is trained for the future. So it's important to speak about it, teach everybody, and go from there. So with that, I hope I'm on time, and I conclude my talk now. Thank you.
Thank you, Harish.
Great.
Yeah. Hey, Alan, you're still here.
I'm here. I'm reading a lot of great questions. Oh, Harish, that was a great talk, by the way. I see a lot of great questions from the audience, and I think we really ought to address a lot of these questions. And thank you, everybody, for joining this talk.
I think mainly the question for you is divided into two issues. The first one is about the which type of operation that should be included for your ERAS program.
Okay, now I think it goes back to what I was talking about, having a balanced ERAS design. If you have an ERAS that fits everything in thoracic surgery, then your program itself, the clinical pathway, is going to be too vague and too generalized, and it won't suit every patient. And then you're going to end up with a lot of exceptions to the clinical pathway. Nobody's going to be able to follow it for the entire length of stay. So you do need to have relatively specific ERAS for every kind of type of operation. But on the other hand, if you make it too narrow, too focused, then again, you're going to end up with about 20 different clinical pathways, and the nurses are going to have a terrible time following everything. So you need to strike a balance. So you might have, like in one of my old hospitals, we had a VATS lung resection protocol. So that would apply whether you're doing a lobectomy, a bilobectomy. It might apply if you're doing a segmentectomy or a wedge resection, and that's fine. But if we're doing a mediastinal surgery, then you do, of course, need a separate ERAS program. So when you design your ERAS program, you need to design it so that a good enough number of patients will actually be using that particular clinical pathway regularly. If you only have one patient who's going to be on that clinical pathway every year, then it's probably not worth writing up a specific program just for that rare case. So you need to find some broad categories. For example, lung cancer, for example, thymoma, pneumothorax. So we ended up with about, I don't know, not too many, four or five programs for the department. And that usually covers the majority of patients, and that's kind of workable. But again, you need to work with the team to find the right balance.
Okay. Yep, and then the second question is regarding the preemptive anesthesia. What kind of anesthetic agent you use?
Yeah, I think a lot of people were asking about the block. Now, yes. Again, I think it's hard for a surgeon to actually demand of the anesthetist, you must give me this block. So you do need to work with your favorite anesthetist and see what we can get. But what works for me in Hong Kong over the years in several hospitals is a paravertebral block. I don't particularly like an epidural. I think it's great for pain control, but it also leads to its own problems. A paravertebral block is unilateral, very localized, good pain control. Give it preemptively. What do I give? Very simple. Just 0.25 or 0.5% bupivacaine, neat, no adrenaline, and that's all you need. And you might say, wow, just local anesthetic, just for, a medium action local anesthetic. Yeah, that's all you need, because you don't need the local anesthesia to carry on into the postoperative phase. Like what I was saying just now, all you need is to cover the duration of your operation. If your lobectomy takes you 2 or 3 hours, that's all the block you need. Okay, because if you block the sensitization of the nerves during the surgery, then post-operatively, even after the bupivacaine wears off, you already preempt the amplification of the pain signals post-operatively. So that's all you need. So some people say, oh, do I need a catheter? No, you don't. If your paravertebral block works, you don't need it. I used to use it very many years ago. We've tried the on-cue pain busters, we've tried various catheters, and actually putting the catheter in, the tunneling, causes more pain than sometimes the surgery itself. It's probably not worth it. So if you have a good bolus block that just covers the duration of your surgery, fine. If you have an operation that carries on all night and it goes way beyond the duration of your bupivacaine, they top it up with some intercostal at the end, but I hardly ever have that situation.
Alan, do you have any experience using this on-cue pain buster?
Yeah, I hated it. There was no need for it. We tried it in various ways. We used the on-cue for the paravertebral catheter. As I said, you don't really need it. It doesn't actually add anything. We tried putting in the on-cue at the wound itself. And as you know, when you tunnel the on-cue itself, as you tunnel it through the skin subpleurally, that causes more trauma than it's worth. And then even if it works, the patient ends up with an on-cue that has an extra thing to carry around for the first day or two of surgery, in addition to whatever drip he might be on, in addition to the chest strain. And it was just more trouble than it was worth. So I personally abandoned it very, very early on.
Okay.
And can I have a little debate between Harish and Alan regarding the suction and no suction?
Yeah. Yeah, I love what you're saying, Harish, and I do agree. I think having no suction is fantastic if you have a prolonged air leak. Personally, what I do though is I do put patients on suction immediately on table, because I use a digital chest strain, and I think it's a fantastic tool. So what I do is as I'm suturing up the wound and chest is closed, I immediately connect to the digital chest strain, turn it on, and we look at how much air leak is coming out. I can't remember if I published this. I probably have it, probably haven't. But what you can see is if you have a very large air leak on table while the patient is still intubated with some positive pressure ventilation, if it's a big air leak, and I'm talking about over 1,000 mils per minute, then you know that patient after surgery, he's going to have a prolonged air leak. I think we have enough experience that we can actually predict that. If the air leak, while the patient's still on table, if it's less than 1,000, usually that will settle by itself. And what we found is that if it's less than 1,000, the patient gets extubated, and there's no positive pressure ventilation, then usually that air leak comes down to just 200 maybe. If you have about 200 mils per minute of air leak on postoperative day 1, then that air leak is going to stop spontaneously. You don't need to do anything within 4 or 5 days. If you have a big air leak as you're closing, then stop closing, go back in and deal with that air leak, because this is your last chance to deal with that air leak. And that's what I do nowadays. Now, I put the patient on post-operatively with a little bit of suction. And the key to that is what you were talking about, Harish, about the post-lobectomy space. If you don't put any suction on it, fine, that's okay. But a lot of patients do end up with a post-lobectomy space. The next morning, they sit out of bed, they start coughing, and that's when they get surgical emphysema. And they also feel discomfort, because if the lung is not fully re-expanded immediately after surgery, the stretch receptors on the visceral pleura get activated when they cough and when it starts re-expanding. And patients feel that. They cough and they feel discomfort. So I always try to put patient on a bit of suction even before they're woken up from anesthesia, and they avoid that little bit of discomfort. They don't have the post-lobectomy space, and then the next morning, or as soon as you get an x-ray and you see the lungs fully re-expanded, you can take them off the suction then, and they don't have the space. So that's what I personally do. And if I do that, I can get the drain out in less than 24 hours, or even less than that if you want. And that's what works for me.
I agree. So I've actually been doing, see, I think that we use the digital suction, the Medela too. And, you know, whatever said and done, I think the -8 still has some amount of suction on it. And so when I really have a leak that I really feel I can't control, I drop it down to -2.
Yes,
and,
that's the key.
Yeah, and so I think that -8 is enough to actually get the lung to suck up, at least from my experience and with my patients. And so I completely agree with you. It's always this debate, what's suck or no suck, you know. So well, in my practice, so far I think most of our lobes are doing okay with -8, and
Yeah.
You know.
One of the great things about the digital chest drain is that when you put it to -8, it really is -8. For those of you guys who are still using the water seal chest drains, when you put it on grouting, on water seal, and you put it down to the floor, if you look at the column of water connected to the patient, that water level rises, doesn't it? Because you have a negative pleural pressure inside your chest. It draws water up, and that column of water actually goes some way towards negating the natural drainage. So actually, I think with the Medela, with the gravity mode, actually you have a more consistent negative pressure out. And I agree with you, that trick about turning it down to -2, fantastic for post-operative air leaks. Fantastic.
Alan, if you don't have the digital device system available, would you still go on suction?
In some of the hospitals where I worked, we didn't have enough of the digital chest drain devices, and when they're all used up, we still use the water seal. So I would still put the suction on just overnight, just to get rid of the post-lobectomy space. Once the lung is up, then we take them off suction the next morning. Okay. Yeah. I think there were some other really good questions here. I think.
Oh, how about tubeless?
Yeah, tubeless. That's a very interesting question. I don't know, Poon and Harish, if you tried it. I mean, I've definitely done quite a lot of tubeless surgery, and you know what? I've abandoned it. I've gone back. To be honest, as a patient myself, I had leg surgeries, you guys know, a few years ago. And the most painful part of my own operation wasn't the wound, it was a damn drain in my leg. And that hurt. And I think looking back at our patients now, a lot of the pain they have post-operatively is from that chest drain. So if you don't have a chest drain in, it should have less pain. But the problem is, what I found when I did patients with no tubes, no chest drain, is that you think you have the lung fully expanded at the end of the operation. You put a suction catheter in, you suck the lung up, you ask your anesthetist to give you inspiratory hold, and you think you have none. but it's always a fallacy. There's always a little bit of air in the pleural space at the end of the operation. And if you don't have a chest drain, and what my own personal bad experience is, some of these patients, they go back to the ward and they cough, and suddenly that air has nowhere to go, and it goes into subcutaneous emphysema. And I had a lot of my tubeless patients, a lot of them did have a bit of subcutaneous emphysema, and they didn't like that. So in the end, I just ended up putting it in all my patients with no air leak. I put a very small bore chest tube in, and I just pull it out the next morning. I think that's a good compromise. Well, that's my own opinion anyway.
I've only tried that on sympathectomy patients, and I noticed that I kept on getting big pneumothoraces even after we suck everything up. So again, like I did, I put in a small bore in, suck it all up, and then in the recovery area, I just pull the tube out.
Yeah.
So that's what I do.
And I think we can have one last question for Harish regarding the residual post-op space and the thoracoplasty. It's a question from Eugene to the chef. You see the question in the chat?
Yeah, in the chat. Yeah, see, yeah.
Yeah.
Do you consider in some cases of residual post-op spaces a superior posterior extrapleural thoracoplasty?
Oh, wow. Okay. So I'll be really honest here. I have, I think, done only one thoracoplasty in my life. So no, I think Alan, you published a paper, isn't it? Or no, not you. It was on muscle flaps and putting it.
Yeah. There are different ways of doing it. You can either stick in muscle flaps. We used to do that for some very complicated resections. Another thing that we used to do is pleural tenting. You just create a pleural tent, and that also works. But ultimately, I think it caused a lot of pain. And if you're trying to do minimally invasive surgery, reduce pain, fast recovery, it was a little bit counterproductive. I think nowadays in the era of digital chest drain, and again, I'm not trying to sell this digital chest drain. I'm a consultant for that company, but I'm not trying to advertise it. But really in this day and age, if you have controlled suction with a digital device where you can actually play with the negative pressure, like Harish says, down to -4, -3, -2, you can actually do a very good job of reducing air leak while gradually not increasing the post-op space. And it works very well. So if you guys can afford it, it's not that expensive. It's worth investing in. Yeah. I noticed one or two other questions.
Actually, there's it's a good question on COVID. Are you applying ERAS during COVID? Actually, that's a question from David.
Yeah, what do you think? Are you using ERAS during COVID?
No. Well, firstly, my population of patients are very different from yours. As much as the patient wants to go home early, they also want to stay in the hospital longer. So, so they feel uncomfortable. They're not sure, although we've taken them through. So my process of ERAS has not been very, I haven't gone extreme like the way you've done it. And we get patients out, I think, by usually 3 to 4 days, but generally they are not so comfortable to go home the next day. Even if you do a simple wedge resection, they always say, doctor, I want to stay one more day just to be sure. And their family insists, and generally I don't want to go into a debate with them. And I said, okay, so when it comes to COVID time, we just stuck to our common practice, and we just got them better and then send them home. That's it.
Yeah, I think my answer to that question is, I think it really depends on the COVID situation in your own country. I think in Hong Kong, even right now, we're going through a third wave, but the numbers are still manageable, and there's no reason to deviate from an established ERAS protocol. I think it's really at the hospital level or health authority level how they strategize COVID admissions to allow you to carry on thoracic surgery practice. And if your hospital or your region can allow you to do that, there's no reason to deviate from ERAS. If the situation in your country, in your region, or in your hospital gets to the stage when your normal thoracic surgery operations are being affected, then not only ERAS, everything else probably has to be put on hold. But I think that's my answer to that question. I also noticed another question here from a Dr. Ismail here, and he was asking Harish, you and I, in Hong Kong and Singapore, do we routinely do an MDT meeting for all our patients?
Yeah, all tumor, all oncology patients, yes.
Yeah,
Yes.
I think it's the same in Hong Kong.
Same. Yeah.
I think it's important really to be objective. And I think the idea of a preoperative MDT meeting is to make sure that every patient doesn't actually get just seen by one specialist.
Yep.
Because as you've all heard the saying, you know, to a hammer, every problem looks like a nail. So if the patient comes to see us as surgeons, our solution to everything is operate. You go see an oncologist, the answer to everything is chemo or target therapy. So it's important to be objective and fair to the patient that they should have an MDT meeting and make sure that they get a balanced program before they go on to treatment. And here's another thing. I think not only before surgery, but post-operatively, you should also report your cases to the MDT, because especially for the pulmonologists, the radiologists, even oncologists, they need to know that, oh, I think this is a lung cancer. I think it's stage 1. They need to know after surgery, what did you actually find? Was this the actual case? And they learn from it. So in future, they can provide you as a surgeon with better service. So I think it's very important for us surgeons to feed back our intraoperative findings to our colleagues.
Okay, I think it's time to wrap up our session. We have a very excellent session for both Harish and Alan. And there's still some questions. I think you can answer those questions later by type the answer to the question. And okay. I'm quite happy that we are now expanding our attendee to Russia. Dr. Chebyshev from St. Petersburg is here. So I think this session is quite a big step forward. You know, we start from last month with 2 sessions a week, and it is nearly 2 months now. So I think next time we may have the people from like the Western countries attending our activity. Okay, thank you very much for Harish and Alan and everybody who attended the meeting. Thank you.
Okay, good night,
Thank you.
everyone.
Thank you, everybody. Good night, everybody. Bye-bye.
Good night.